I'm Dr. Judy Salerno, President of the New York Academy of Medicine. Thank you for joining us today for our Around the Table series, where we discuss issues related to health equity, the heart of our mission, and specific relevance to the times we're living today. As you all know, discussion and exchange of information is critical, but so is taking action. After each program, we offer resources and recommend action steps you can take so you can all engage and help us to move closer to our shared mission to advance health equity. We hope you will listen in, engage, and take action, because making meaningful change will take all of us working together. I'm pleased to be here today with Dr. Wayne Riley, President of SUNY Downstate Health Sciences University and the Chair of NYAM's Board of Trustees, and our special guest, Dr. Catherine Lucey. Dr. Lucey is Vice Dean for Education and Executive Vice Dean for the School of Medicine at the University of California at San Francisco. She directs the undergraduate, graduate, and continuing medical education programs of the UCSF School of Medicine and the Office of Medical Education. In various roles throughout her career, she's worked to influence the direction of academic medicine and the continuum of medical education in ways aligned with innovative approaches to education, culture, and community. During the first year of the pandemic, she co-authored an amazing article on the very topic that we're discussing today. In it, she mentioned that the COVID-19 pandemic can be viewed as a catalyst for the transformation of medical education that has been brewing for the past decade. We're so pleased to have her with us today to share her thoughts and to join in this conversation. Welcome, Dr. Riley and Dr. Lucey.
Thank you, Judy. And it's a pleasure to join you and Dr. Lucey and to be a part of the New York Academy of Medicine's action-oriented programming. Now, today we're focusing on how the lessons learned from COVID will shape the way we teach our medical students and guide physicians in the future. As Dr. Salerno mentioned, this is work Dr. Lucey has been doing for quite some time. And so we are anxious to hear from you, Dr. Lucey, who we consider one of our nation's foremost experts on medical education. We saw and felt the impact of our healthcare professionals during this pandemic, especially in early 2020 when we didn't know how much we know today. And impressively to those of us who work with Judy on a daily basis at the board of trustees of the Academy, Judy came out of clinical retirement to volunteer her time as a physician. And this was, again, testament to her great leadership skills and her deep commitment to being a superb healthcare professional and physician. And Judy, I'll kick off our discussion with Dr. Lucey by asking you this. Tell us about your experience, pulling out your stethoscope and getting back into the clinical arena during the height of the pandemic.
Well, it was quite a shock. I've been a doctor for 35 years, and I was thrown into a situation where I felt like an intern again. And I was working in the ICUs with newly minted doctors and medical students, a number of them fourth-year medical students who were graduated early to become doctors on the front lines. And they certainly were more up to date than I was with ICU care. But what I saw was, from the eyes up, were the stress and the distress in their faces every single day, particularly as we were overwhelmed. At one point had 225 patients on ventilators, the vast majority of whom in our large public hospital where we were working, who were people of color, Black and brown patients, and many were dying because we had no idea back in March and April and May of what to do, how to treat COVID-19. So it was amazing. We talked and we discussed the disparities, the stress, and we had a number of people who had meltdowns. The ICU rotation was limited to 2 weeks because the stress was just too much. So it really said to me that we need to do something better. We need to see something baked into medical education. Our systems need to help deal with the inequities, to help our trainees understand what's going on and to see what they can do to help address the inequities. And I was so concerned after 18 months now about what really what's the effect on these young doctors, and what's the stress? I'm worried about them. I'm still worried about them. I ran into one of the interns I had worked with at Bellevue on the street. And when he saw me, he put his arms around me and started crying. This was a year after we had worked together. So we need to do something to help with their well-being, to help them be lifelong learners who don't start their careers burnt out, and to also preserve the compassion that brought them to the profession of medicine in the first place. So it was really a wake-up call for me as to, how we have to approach how we train medical professionals with the lessons that we learned. And I like the Catherine's article, which talks about this as a catalyst. And I think we have to start thinking more like that. So, Dr. Lucey, it was wonderful to really read your article so early in the pandemic, and it's so cogent now as we continue to think about what our post-COVID or our endemic COVID life will look at.
Thank you, Dr. Salerno, and thank you for your service. Returning from retirement was really an extraordinary feat. And I'm so happy we're talking about this with this broad audience here. And I'm very honored to be on the same Zoom with Dr. Riley and Dr. Salerno, who I've been such great fans of for their entire careers. A couple observations I'd like to make just to start us off, and that is, it is important for us to recognize that the work that individual physicians and other health professionals did during this pandemic was extraordinary. And we can have a lot of pride, those of us in the academic medical centers and medical schools and residency programs, about the ways in which we trained physicians to respond to these crises like the pandemic. Every type of competency that we focus in on, from being able to use basic science to reason through a new pandemic, or clinical science to figure out what to do when you don't have enough ventilators and maybe you should think about prone ventilation, to the professionalism that we saw people rolling up their sleeves and staying late, and in many ways having someone else care for their own family so that they could care for the loved ones of people who were dying in the hospital. I couldn't be more proud of my profession and the way the individual physicians worked during this time alongside of the other nurses, physical therapists, respiratory therapists. So I think it's really tempting to sort of say we need to change everything. But first, we have to sort of acknowledge what powerfully good clinicians we've had and powerfully good scientists who have been educated in our schools and our residency programs. With that, however, I think the pandemic really displayed to us some real workforce challenges. So as individual physicians were fantastic, it became very clear that we do not have the workforce that we need to tackle the problems that we're going to tackle in this century, in these next 20 to 40 years. And it's, I think, insufficient for us just to say that we have to train people for the inevitable next pandemic. Certainly we have to do that because there will be another one. But more importantly, you talked about the tremendous healthcare and health disparities in communities that have been historically excluded or marginalized or exploited by medicine. If we really want to improve the health of our communities and eliminate suffering for our patients, we have to train our workforce in a different way to be able to have the skills needed to tackle those healthcare disparities with the same fervor and persistence and tenacity that we saw them tackle this pandemic. Because after all, articles document that about 75,000 African Americans die per year in excess of their Caucasian counterparts because of healthcare disparities. And That's the next 10 years. If we could solve that problem, we will save as many lives of people of color as we could have saved in this pandemic had we been better prepared. So I think, thinking a little bit about what does it mean to train a workforce that is distributed appropriately, the right specialties, the right geographic locations, with the right skills to manage things like a pandemic or switch to telehealth, and the right understanding and lens to tackle things like healthcare disparities, like climate change and its effect on health, like public health threats from wildfires. Those are types of things that are not incorporated consistently in today's medical education. And we have to do a better job of preparing this generation of physicians to solve those problems and to fulfill our commitment to our communities that have been so badly damaged over the years.
Yeah, Dr. Lucey, thank you for that. I couldn't agree more. And like you said, that great article you wrote kind of, crystallized in my mind exactly what you just covered. But I want to throw something at you that Judy and I have talked about, and many other medical education leaders is, as you know, during the very beginnings of the pandemic, the LCME basically asked all medical schools to pull students out of the hospitals. And this was quite controversial in many places. It then led to an extended period of virtual learning. And again, I began to have serious concerns, Dr. Lucey, about the lack of professional development that our students were missing because they were sitting home, on Zoom all day, or Teams or WebEx studying medicine. And so I've been sort of a little bit of a heretic in that, look, you can't phone in or Zoom in becoming a physician. You have to be at the bedside. You've got to be, engaged in the care, even at the second and third year level, I would argue, because some of the greatest lessons I got as a medical student were being around physicians. I saw great role models, but then I saw not so great role models. And I knew I did not want to be that type of physician. So how would you, how do you feel about that tension that we're now feeling in medical education circles, particularly at the undergraduate medical education level?
Yeah, this is great questions. And when we talk about what are the learnings from an educational process or methodology perspective from the pandemic, there's a lot of excitement about, couldn't we just move a lot of this work to the virtual environment? And I think, first off, I want to say that there is a role for the virtual environment. The way we had to use it in the pandemic was far too extensively. And I think, Dr. Salerno, you talked about the compassion and the mentorship that happened when you were one-on-one with people in the ICU. And you created such an impact on that learner that they were able to open up to you a year later. And so thank you for that. But I think you're exactly right. The fact that we could train students through Zoom and keep them graduating. I think one of our principles we all operationalized was we have to graduate a class every year. We can't sort of wait a year because we have to be able to produce those pandemically prepared physicians. And so we did what we had to in the setting of a crisis. But of all of the educational innovations we did in the pandemic, the one I hope does not persist to the same extent is the online learning. I think it is really hard to develop compassion, teamwork, peer support when you only see the avatar, the two-dimensional avatar. And I think we are getting it back. We did not adhere to the no students in the clinical environment because the context of our COVID pandemic provided us with enough patients and enough non-COVID patients so that we felt our students could learn in the clinical environment. We had to dial it back to some extent because faculty bandwidth, PPE shortages early on, and we have, though, since that time, really prioritized the education of people who are in their clinical years in the clinical environment to, I think, the benefit of them. And right now we are going back as of beginning of February to in-person lectures because that socialization and ability to engage in scientific discourse and argument to learn, that's much better in person than it is on Zoom. So I share the concerns that you have, Dr. Riley. There's a lot of good learnings that we had about other strategies that I hope will persist from an educational perspective, but online learning should be taken with a grain of salt, and maybe, it's like a Starling curve. Too little is bad, too much is bad. You got to kind of get the Goldilocks point.
It's interesting. I had a session with first and second year medical students a couple months ago on Zoom, and they complained. They called it webside, not bedside, and they were they said that they were really starved for being in a clinical environment where they could learn about how to talk with patients. And I think that, in addition to thinking about the getting back to some in person for those sorts of things, which are so critical to development as a physician and a health professional across all the health professions, there are really some new competencies that we have to really develop and further develop that were kind of forced on us very quickly in the situation we found ourselves in 2020. I'd love to hear your ideas about what of those new innovations, those competencies, what should we keep?
Yeah. So I think from a preparing physician's perspective, one of the things I believe we've tried to inculcate in our curricula is kind of an anti-medical school approach, meaning in the old days, we taught medical school as here's a canon of knowledge, memorize this all. So that you can be kind of a walking Cecil's or, Harrison's or whatever textbook of medicine or surgery that you used to use. And we crammed our curriculum full of facts and prototypes and things like that. I think the pandemic showed us is the critical importance of teaching people how to question what we don't know and how to actually read the literature and use your basic science knowledge to reason through ambiguous problems or emerging problems. And so I think a key theme in a lot of medical education going forward will be that managing uncertainty, dealing with ambiguous, complex problems, and recognizing that virtually everything we saw in the pandemic was not a function just of a derangement of human biology, but a really complex interplay between human biology, adverse social policy, a global pandemic, and then sometimes dysfunctional or inappropriate healthcare systems. And so if a physician or a group of physicians, a workforce, wants to make a difference in those areas, they have to have sort of core fundamentals in things like health systems and health systems improvement, public health initiatives. Human biology will always be a critical part. An important part that we've seen is really critical is public communications and engaging people in becoming trustworthy to individuals, which we talk about sort of abstractly, but I think we could do a lot better job to sort of teach the elements of what it means to be trustworthy, particularly to populations that are appropriately skeptical because of their past bad experience with the medical profession. So I think that, this idea of teaching people to reason through, to use science to rationalize how to approach a new patient, to engage in cultural humility and talking with populations and communicating things, and also to advocate. I think advocacy is something we shied away from in the 20th century. We will not solve the problems we have in front of us with health and healthcare disparities and environmental disasters related to healthcare if physicians sit by quietly. We are going to have to learn to communicate effectively with policymakers, legislative individuals, government elected officials, and things like that. So in addition, you have all of the other things like how to do telemedicine appropriately, how to manage palliative care in people with acute illness. But I think much more importantly are those issues, the inquiry, the discovery, the advocacy, cultural humility. Those have to be front and center of the skills that we're trying to inculcate in our learners.
Yeah, again, this is such a rich discussion, Dr. Lucey and Dr. Salerno, because, we think about all these issues and pivoting now from our undergraduate colleagues who we're educating to our postgraduate. And I know, Dr. Lucey, you oversee the entire medical education and training continuum at the great University of California, San Francisco School of Medicine. So talk to us. Well, what are your house staffs telling you and sharing with you and your team about their experiences trying to learn to be a doctor, and then dealing with a pandemic? I jokingly say to non-physicians, by the way, there is no course in medical school called pandemic. We didn't get that, but we did. I missed a day, and I never missed a day of school. So talk to us about your house staff and your GME issues, and how you've looked at that sort of critically and analytically as you superbly do.
Yeah. So first, I want to just give a brief historical observation. I did my training at UCSF back in the 80s, right in the beginning of the HIV
era.
Yeah. So probably similar to you. And at the time, I have to remember as a trainee being devastated by seeing the suffering and the death, particularly of people who, were similar age to me, looked like my brother or, my next door neighbor or something. But I will say in retrospect, that really shaped my entire career. It shaped the way I understood how critical it was to meet people where they are, to work with the public on public solutions to health issues, to work with basic scientists on finding new ways to do things, this interprofessional collaboration. So in the midst of it is sometimes hard to take the long view, but I think people will be pleasantly surprised, and look back and sort of say, this shaped who I am as a doctor to have worked during this pandemic. The residents and fellows were just remarkable. They were professional. They supported one another. They flexed where they needed to flex, moving surgeons, because we canceled elective surgery. Surgeons worked in the ICU or in the emergency department or on medicine wards. And they did what was necessary to make sure the patients were getting cared for. It's hard work. It's hard work, for example, wearing PPE all day long. They too kind of felt isolated from their colleagues because of social distancing and because of PAPR suits and PPE, and the inability, at least in the early pandemic, to even socialize after work. And so, there were some interns started and they didn't meet anybody in person other than through their PPE until, midway through the year. So I think it was really amazing. I will also make a secondary observation. Then I want to talk about wellness. A secondary observation I found in the pandemic to be just fascinating as an educator was people were so hungry for knowledge about the pandemic that our medicine grand rounds, which was very well done, I got to congratulate Bob Wachter, who is the chair of medicine, would have, thousands of people signing up, 5,000, 6,000 people every week to see the latest about the pandemic. And those people ranged from first-year medical students all the way up to emeritus professors. And guess what? They all were able to learn from the same content and to internalize it and actually keep going with the next step that they needed. So I think that's a lesson for us. We spend a lot of time tailoring things to different groups, when pushing out information in the setting of crises like the pandemic worked really well. And we should think about that with, for example, healthcare disparities or environmental effects on health. The other point, though, I wanted to raise is going back to Dr. Salerno's comment about wellness. I think wellness is a very, very serious problem. And I think that the pandemic showed us that interventions by institutions that support physicians, nurses, physical therapists, all health professionals to do their best for their patients really did help. There was a time of extraordinary work, and, institutions really UCSF and others really stepped up to the plate. They found meals, they got chaplains to come in, they found housing for people who needed housing, they fixed childcare issues. And while people were still tired and dealing with a lot of things, what it showed me is that if we put our workers, our healthcare workers, front and center surrounding our patients and make sure everyone can do the job that they need to do, we can actually help people have a better work life without as much burnout. And I do think we're going to need to wrestle with issues of overwork, pajama time related to the electronic health record, sort of performance metrics that are really excessive. And one of the things that probably will come up again in the next 10 years is 80 hours really the right amount of work for a new trainee to be working? I know that's not a popular view for an educator to espouse, but it does feel a little bit like, a finger in the dike when you sort of say, well, you should have a better wellness approach, but you have to work 80 hours this week. So I think we learned a lot about the impact that institutional and systems changes can have on well-being in the midst of a crisis. And I hope that actually extends to post-crisis times as well.
I wonder if we're at a point where we need another Flexner report. Where do we need just to think about new learnings, new competencies, or do we need a complete overhaul of the system? I know, there's been a lot of discussion about more lecture, more content around things like health equity issues. But shouldn't those kinds of things be infused throughout our entire curriculum and all of our learning so that they become part of, if you will, the DNA of medical education? I think that it's been really a struggle whenever we see that there's something that's needed for our learners. We put in a lecture, we put in a clerkship, but we don't look at the effects throughout the entire learning, and not only through medical school and residency, but physicians and other health professionals are lifelong learners, need to be, with the changing scientific knowledge and the environment. So I think that we have some real challenges about whether or not we need an entire relook at the way we have organized our education for health professionals.
I totally agree with you. My colleagues, John Davis and from UCSF and Marianne Green and I wrote a paper for the Macy Foundation with the title, "We Have No Choice But to Transform Medical Education in the Post-COVID Era." And we laid out a 10-point, 10-year plan to redesign medical education to better serve our communities and our patients. And I think it is sort of a call for a rethinking of medical education at the level of the workforce as well as the level of the individual. I mean, the fact that there are communities still that had no doctors or did not have the right doctors in the United States, it's such a great country, is a failure of a workforce plan for us. And, it's one thing to have individual physicians, again, with incredible professionalism and commitment, fly into the Navajo Nation or to a underserved hospital in Queens. But when they fly out again, that community is still underserved with regards to their chronic healthcare needs. And so we need a workforce plan, and we need redesign of all aspects of education, as I think you're alluding to, Judy, from undergraduate medical education to continuing medical education and continuous certification, to teach people what they need to know to tackle the health manifestations of structural racism and structural oppression. We can't just say we're going to teach this graduating class about this and hope that eventually when they get down to independent practice in 10 or 15 or 20 years, they'll change. We actually have to simultaneously teach practicing physicians, current residents, current fellows, current medical students, and we have to redesign systems with a clear lens as to where our medical systems and our educational systems continue to perpetuate disadvantage for communities or for learners from underrepresented environments. So I couldn't agree with you more. I think if we as a group of leaders of what I call the medical education ecosystem, which includes medical schools, residency programs, academic health systems, accrediting bodies, regulatory bodies, board certification bodies, if we put our patients and our communities at the center of how we design education, then I think we have a real opportunity to actually meet people where health health is sustained and illness begins, and to hopefully prevent people from dying from and being disabled from preventable illness. I think it's a really exciting opportunity, and the pandemic has really showed us where some of those fault lines are. And so I would love to figure out a way to get people like Dr. Riley and yourself on board with a national movement that says we are going to change after the pandemic, because we no longer think it's acceptable to have this many people die of a pandemic, or this many people continue to die with preventable diseases because of health disparities.
Yeah, great points. Now, I want to hand you another medical education hot potato, Dr. Lucey.
Oh, good.
And this is the whole issue of the fourth year, and whether the fourth year is really all that value added. And, much has been written about the fact that the fourth year tends to be comparatively lighter objectively than the first 3 years of medical education for the our UME colleagues. Some schools have gone to a 3-year. Some have looked at how do we make the fourth year more value added. For example, and I know this happens at your great place too, we have a lot of students who want to pursue a second degree, whether it's a MPH or MPP, MBA, Master's in Education, a law degree. And so part of it is their pent up demand to get the skills for what you just referred to is being better advocates and also physicians. But what say you about the fourth year, Dr. Lucey?
Yeah, what I say is this. I know. We are structured by the constraints of the National Residency Matching Program. I'll probably get in trouble for this, but we are structured by that to a very altered fourth year of learning, because so much time medical students spend on applying for, traveling to visit, and then working through the match, right? It's the major role of the fourth year is to have people find the residency program that they are going to match into. And the system is, I think at this point, really in need of overhaul. One of the great innovations of the pandemic was virtual interviews, which allowed people to stay home, not waste time traveling. And still, I think all of us got the classes we wanted, the residency programs we wanted, and the students are happy with their matches. We have put way too much emphasis on the need to visit 10 or 15 or sometimes 20 programs to find the right one.
Or additional electives, that was another.
Additional electives, another one. And not to mention the expense, which creates some inequity in students that come from families that don't have added wealth for them to support additional traveling. So I think we really need to think a little bit about, could we streamline this process? Is it possible that we could, for example, sustain virtual interviews and maybe even restrict them? Are there phased matches that would allow some students to then sort of navigate into an MPP or a secondary degree? Could we have twice a year match so that people who graduate early have something to do rather than wait for 6 months with no health insurance and no income, because you can't really take a 6-month job? So lots of questions there. I think your point also, though, brings up another thing that I saw work well in the pandemic, which everyone thought couldn't work, which is a change in assessment to more competency-based assessments. We saw the American Board of Medical Specialties and its member boards move away from specific volume or numbers of procedures, and instead as criteria for board certification or board eligibility, and instead took the measured assessment of a program director to say, this person is ready to move on because, some of those surgical procedures were not available. We also saw, as Judy said, some students who got to graduate early, despite the fact that they hadn't quite finished their medical education curriculum. This move towards competency-based training has been recommended for at least a decade. Everyone says it's too hard, but in the middle of a crisis, we were able to do it. So if we could do it in a crisis, that means we can probably do it. And I think that's the other thing that this pandemic showed us, that things we thought were not feasible are not only feasible, but maybe desirable. And if we were able to go to a competency-based training model, people could either graduate early, they could take additional time to get a degree to become what I think is going to be a new set of like translational physician roles, like the physician advocate, the physician anti-racism, the physician public health expert. Or they might choose to do something like family building, childbearing, child rearing, without having to take an extra year off or something like that. So I think competency-based training with some level of time variability was shown to be feasible during the pandemic, and I would love it to continue on going forward. But it has to be something we would agree to as a country, as a medical community. It can't happen just in one medical school because our students move between medical schools and different parts of the country.
Great. Well, absolutely great ideas and great discussion. And we want to remind everyone to click the link at the end of the program to learn about the number of other resources and information that we have laid out for you. Put the recommended solutions and actions that I think Dr. Lucey has envisioned, that Dr. Lucey has shared with us into practice in your work with our learners, both our young physician learners and our undergraduate learners. And have a discussion with your peers over coffee or pizza or beer or a glass of wine. I think, again, those are some of the best discussions we have as educators, is those somewhat relaxed times where we can really debate, discuss, listen for alternative points of view that might be helpful to making us all better medical and health professions educators. So basically, what can you do to shape the future? As Dr. Lucey just laid out, I think she laid out some very wonderful ideas that I had not thought of. Wow, a 2 times a year match, that makes perfect sense. So again, that is just terrific. So let me turn over to Dr. Salerno for her final thoughts, and then we'll conclude this wonderful conversation.
This has been an extraordinary discussion. And again, I've learned so much as well. And I want to thank Dr. Lucey for joining us today, for her amazing work in medical education. Keep it up, and we will join you. We will start a movement. And I'd like to thank you for sharing your thoughts, and to ask you if you have any final comments you'd like to share with our audience.
Well, it's been a fantastic opportunity to get to talk to this really wonderful audience. What I just encourage people to think about is when you went to medical school, the medical education you received was perfect for the time in which you went to medical school. It does take some imagination to say that maybe now we need somewhere different to go with medical education. So I just encourage you to engage in those conversations that Dr. Riley talked about with an open mind and with a focus on the patients and families in your community that may not have been well served by medicine in the past. I think all of you put your patients first every single day. And if we can put whole communities first for our medical education programs, we'll be better off for it. So thank you so much for letting me participate today. Great.
Thank you, Dr. Lucey. That's why you're one of our nation's treasures as a medical educator. The wonderful dialogue that you've stimulated and thought processes in this session. So again, thanks to everyone again, and we'll be back with another wonderful conversation in around the table discussion as we've had today. Again, don't see this as a passive exercise. Use these discussions to take action, even if it's just within your course or your clerkship. These sometimes these little changes can sort of snowball into bigger reforms that are much needed, as Dr. Lucey just laid out. And again, thank you again to my wonderful colleague, Dr. Salerno, who leads our treasured New York Academy of Medicine with distinction. And again, we look forward to seeing you soon.
Click on the link at the end of our program, which will give you resources that can give you more information and to stimulate you to take action. So thank you for joining us today.